kind of speaks to a lot of telehealth providers out there, is that you kind of operate in this hybrid space. So where you define yourself, more on the EHR or platform side, or on the network of provider side and services side, will determine, your integration strategy and how you approach the regulations and how they implicate, what the implications are for your business.
Hi, everyone, and thanks for joining today. Really excited to spend some time this afternoon talking about healthcare integration. I'm a pretty big nerd about it. Before we dive into that, the thing I want to say to break the ice, because I get asked this question all the time, is where the heck am I sitting in my house? I'm actually in an upstairs hallway. So if you see doors peeking behind me, they're not random offices. They are just closets. If you want to drop in where you're working from today too, that might be kind of a fun way to see how many of us are back in the office or making do from home. I'm based in Madison, Wisconsin, so I'm coming to you from the Midwest. I'm Paige Goodhue, for those I haven't had a chance to chat with or haven't gotten an email from me from Redox. I'm the Director of Product Marketing here. The content for today's session was inspired by one of Redox's company values, which is to educate each other in the world. A lot of what we're talking about came from an internal class that we do here at Redox to help our team better understand the healthcare integration landscape. We know that understanding the options that are available and when to use them are critical when it comes to developing your product's integration roadmap. Our goal today is to share our knowledge and some of the lessons that we've learned from the over 800 integrations Redox has done, as well as experience from other healthcare companies we've worked at in our prior to Redox lives. So we're going to start by doing some introductions of the folks that you'll be hearing a lot from today. They're going to share some of their background and also give you the fun story about where it is that they're working today. So we're going to start first with Nijay Patel, who is Redox's VP of Product. Nijay?
Thanks, Paige. As Paige mentioned, I'm the product lead here at Redox. I joined the team back in 2015, which feels like a lifetime ago, especially with the year 2020. But over the course of the years, I've had a chance to work with so many different vendors on the integration strategy, and then as they've tried to deploy those integrations across the country with various health systems, payers, HIEs, you name it. So excited to dive into my favorite topic today on integration. On a personal note, I'm a recent transplant to LA. I moved here from Chicago, so enjoying some of the Southern California summer weather right now. And I've been pleasantly surprised by the growing health tech community here. So that's been exciting.
Awesome. And where in your house are you working from today?
Oh, yeah, of course. I am in my guest bedroom, which happens to get the best internet. So.
Oh, I might have cut out there. Very kind of you to make sure your guests have good internet, Nijay. And Yi, tell us a little bit about yourself. Yi Liao is here. She's in charge of product strategy at Redox. Yi, I know you just moved into a new house, so we're all dying to know if the wall color behind you is going to stay as you start to settle in.
Hi everyone. I'm Yi, and indeed, I am coming to you from Denver, Colorado. Last week, my husband and I just moved to a new house. So I'm sitting here in a pretty empty office room with 3 unpacked boxes sitting next to me on the floor. This wall color, I think it'll depend on how lazy we feel once we furnish the rest of the house. But it'll probably stay for the time being. But a little bit of a background on me. I joined Redox back in September of last year, which also feels like a lifetime ago at this point. And I came to Redox after about 4.5 years, working in telehealth across 2 different companies. One was Video, VIDYO. On the technology side, I was the product manager for the Video Connect platform and worked with some of the largest health systems in their telehealth programs. And before that, I was the product manager for General Telepsychiatry, which was a telepsychiatry platform, which then went on to become acquired by Optum Health as part of United Healthcare. So very, very passionate about telehealth as a field. Purposefully recruited for it after business school, and now I'm excited to be here today.
Awesome. Well, let's go ahead and dive in with everybody's favorite topic, regulations. We're going to start here just to kind of clear the air. There's obviously a lot that we've been learning since March when the ONC data blocking regulations finally dropped. That final ruling was announced. A lot of that has been a little bit in the background for folks that as we've been dealing with everything going on with COVID-19. But at the same time, when you are developing a healthcare product that you expect to integrate, I'm sure it's at the forefront of many of the minds of the folks that have joined today. I know that there's some hope that the implementation of these regulations will help increase interoperability and reduce the cost of integrating across the board. Nijay, I know that you have been doing a lot of work in basically diving into and understanding as much as you can about these regulations. We've been looking at it at Redox to make sure we know where we're impacted, as well as to get a better understanding of what our customers might be facing. So would love to hear from you on how you think the recently passed data blocking regulations will impact interoperability for software vendors.
Yeah, happy to dive in. You've certainly picked quite a meaty topic for us to kick things off with. And I think, the 21st Century Cures Act and the regulations and associated mandated APIs is certainly deserving of its own deep dive discussion. But at a high level, generally we're really excited about the regulation. It's the intention behind them and then the expected impact that we have to the industry. It's important to keep in mind that these regulations are going to impact lots of different groups. Payers will be impacted, certified EHR vendors will be impacted, provider groups will be impacted, health information networks will be impacted. And when we think about telehealth, it can become really confusing as to which of those buckets does a solution fit squarely into. So that adds to the complexity here. I think right now, it's important to keep in mind the regulations are final, they're coming. Try and stay on top of them and plan accordingly as you're moving forward.
And Yi, I know you obviously have really deep background in telehealth. So as Nijay mentioned, sometimes how telehealth vendors can operate will change how they might be impacted. I'd love to hear a little bit about your experience.
Yeah, I think especially important for telehealth providers. We sit in this is very, very specific area at the intersection of kind of services and technology. And I remember back at Genoa Telepsychiatry, one of the biggest existential questions was around our business model and whether we were a staff augmentation company that was powered by a lightweight EHR product with video conferencing capabilities, or were we a telemedicine technology platform supplemented by a network of providers. And I don't think we ever landed on quite a clear answer. And I think that kind of speaks to a lot of telehealth providers out there, is that you kind of operate in this hybrid space. So where you define yourself, more on the EHR or platform side, or on the network of provider side and services side, will determine your integration strategy and how you approach the regulations and how they implicate what the implications are for your business.
I think it might be worth just double clicking on the US CDI standard set specifically, just briefly, and I could talk for hours on it. But one important thing to keep in mind is, what's been published in the mandated APIs is just the first step forward. And we certainly expect to see that scope to increase and look forward to that in the coming years. But currently, we should expect read-only APIs. So the more complicated bidirectional workflows will still need to use alternative means of integration. And then, as we've seen historically with regulation coming along and being implemented or adopted or having an impact across the industry, it's going to take a long period of time. So we're in this awkward transition period. In the next 2 to 3 years, it's a high level of uncertainty. Some vendors might be much sooner to adopt. Others might be a little bit slower. The HL7v2 will certainly continue to play a prominent role. But I think understanding the scope of what's being mandated as this like first step is really important. Things as simple as scheduling an appointment won't be in scope. So you can read a provider's upcoming appointments, which is really helpful, but if you have a no-show, you still need to be able to write back and let the source EHR system know that that patient didn't show up. You'll need to use alternate means of integration for that.
So Nijay, one of the things that you mentioned there is that this is something that we're going to see over the next few years and that's going to be evolving. I know at Redox is something that we've thought about, so would love to hear your insights on how should people be thinking about the implementation of these regulations in the context of their bigger product plan? Like, is this something people be planning now, or is it something to put off, knowing that it might not? It might be a few years before we're seeing this full implementation of all of the regulations.
I certainly wouldn't recommend putting it off in terms of the analysis and understanding where do you stand, and will you be impacted? Will there be requirements or things for you to do as part of the data blocking regulation or information blocking regulation? In terms of incorporating the US CDI standard and the FHIR APIs into your integration strategy, that level of variability likely means you want it to be a tool in your tool belt, but can't have it be the only strategy. We've already seen the timeline shift, and shouldn't be surprised if the ONC comes back with additional updates, both in terms of the scope and the timelines. As payers and EHRs, the largest provider networks in the country, start to wrap their heads around what this means for them and what they're going to have to do for to remain certified. Obviously, that means we need to be extra vigilant for vendors and emerging areas of digital health, such as telehealth, because those might not be at the forefront of the largest impacted parties as we move forward.
Yeah, I think many of us that have been in healthcare for a while remember the sliding ICD-10 dates. So we definitely have seen that happen in healthcare over the years. Really great opportunities to make progress, but sometimes it takes a little longer than expected. Kind of speaking of regulations, we don't want to spend a lot of time today on discussing how the relaxation of a lot of regulations, especially around payment, really have helped telehealth grow as quickly as we as a country needed it to in the world of COVID. There's been a lot of great discussion about that already. I'd love to hear, though, from your perspectives, as a telehealth vendor, you've had a really great opportunity to get into healthcare organizations and get implemented quickly. What are things to think about doing now to ensure that there's ongoing stickiness, especially in the case that there's any sort of pullback that happens on some of the payment regulations or the different pieces that have been kind of thrown out the window in this time of need?
Yeah, I think I'll speak to that. Coming from a couple different telehealth companies, I know that there are kind of three vectors where we view where we could differentiate from the market, because telehealth does cover many different aspects. You have the technology aspect, you have the services aspect. So you really can think about these three vectors being: one, can you scale? Two, are you secure? And three, how integrated are you with the provider's EHR systems, practice management, revenue cycle billing management systems? So with a lot of the relaxation and rules and HIPAA regulation around the security piece, that's actually kind of been rolled back a little bit during this time period, but that doesn't mean it'll go away. But as the core technology pieces become more commoditized, at video, we used to say, video conferencing tools are a dime a dozen. That's become a commodity basically these days. And secure encrypted video, also dime a dozen. So that's really hard to differentiate yourselves on nowadays. So then you look at the other two vectors, one being scalability. Can your network, can your services, can your infrastructure scale with the level of volume that's going to take, especially right now in the explosion of healthcare, telehealth adoption. And then the third piece is critical, because you have to give providers essentially the peace of mind that they will be reimbursed just as much as before, that you can make sure that their patients are followed through from beginning to end, and that you're going to give them the proper clinical documentation that's required by their payers for reimbursement. And with that, the essential piece is integration. I know that there's been a recent survey that 30% of providers are most concerned about data integration when it comes to telehealth implementation. And there's a strong reason for that. The documentation piece, the patient intake piece, eligibility checks, all of these things that lead to the providers getting paid at the end of the day requires that technical integration.
Yeah, especially at a time when many healthcare organizations are, facing significant decreases in their income, making sure that they've got the systems in place to provide that telecare to patients and still be able to get the appropriate reimbursement so they can keep their doors open. Excellent. So now that we've spent a little bit of time on regulation, we're going to move into what is really the meat of what we want to talk with you all about today, which is really sharing and diving into our view of the healthcare landscape and giving some of those nuggets that we've learned by integrating with these various healthcare data sources out there. As a quick context setting, I'm going to share. Hang on one second while I get this ready to share. But I'm going to share just a quick visual of how we think about the universe of healthcare. We talk about them as healthcare data sources in terms of the different ways that you might approach your strategy for integration. Give me 1 second, having a little technical difficulty. Come on, computer. All right, well, I'm trying to get this graphic up. I'll start by explaining that there's kind of 3 different types of major healthcare data sources that we think about. The first is what we refer to as trusted networks, which are basically interoperability networks such as Care Equality and Commonwealth, as well as health information exchanges, which are typically state-based. There are some that are private or more regional. And direct messaging via HIEs. We think of these a little bit differently in that they usually are a single type of data source that you're connecting to with the ability to work with a variety of different providers without having to create that direct relationship via a BAA necessarily. The second category are the EHR vendor APIs. We hear a lot about this today and are expecting to see more and more of these becoming significantly more usable than they've been in the past. The 3 variants in which we think about these are patient auth APIs, and then APIs in the sense of how do we technically access and use those APIs. We'll touch a little bit on kind of some of the nuances we've learned from integrating with a multitude of these. And then also the world of the vendor API marketplaces. And what does that actually mean when you think about it as a piece of your healthcare integration strategy? Mm-hmm. The third type is kind of the more traditional way that integration has happened, which is organization provisioned access. So these are those point-to-point connections that are done directly with the healthcare organizations. Typically, you are connecting to their EHR system or their other type of system that's in place, like a CRM or an inventory management system, and really doing direct integration that's typically event-based in some sort of a format. The other 2 things that we put under this idea of organization provision access is the US CDI on FHIR. That's a mouthful, which Nijay touched on a little bit, but that's something that as the data blocking regulations come into play, we'll see a lot more of that. But it still does require that organization to have the ability to provision that access. And then provider authorization APIs. This is something that's a little bit newer, but we're starting to see more and more healthcare organizations and EHR vendors working on figuring out how do we help providers be able to access the solutions they need, and how do we use that as a way to control the appropriate access. I don't know that my graphic is going to come up because my computer is moving a little bit slow, so we'll go ahead and just dive on into the first one, which are those trusted networks. This is something that Redox has been doing a lot of over the past year. So Nijay, I'd love to hear your thoughts on kind of some of the things that we've learned about integrating with these trusted networks and when they're really a good idea for a part of your keystone of your integration strategy.
Sure. Yeah, I think, as you mentioned, I mean, trusted networks, including Commonwealth, Care Quality, HIEs, the Direct Trust Network, they've been around for quite a while, and were originally, most of them were implemented to facilitate provider-to-provider communication, and specifically the transition of care within the umbrella of patient treatment. So for the most part, we'll see a CCDA as the core method of exchange, which is a pretty comprehensive standard and document for getting a snapshot of the patient history that can be really valuable. And preceding that will often be a pretty basic patient search capability, so that, based on demographics, you can find the patient that you're interested in. So generally, I think telehealth, it's a great example of the type of platform that can take advantage and leverage trusted networks. There are a lot of advantages to using a trusted network as part of your integration strategy. And at Redox, we've seen a huge spike in interest and utilization of these. Generally not a comprehensive integration solution, but a core component of it, especially to get that, snapshot of the patient history prior to a visit for a provider. The two big things that I think trusted networks accelerate or provide are, one, simplification of the authentication or agreements with health systems. Rather than having to go to every single health system one by one and negotiate agreements and sign paper, you can join one of these trusted networks, and it's a single commitment or contract, and then you have access to the entire network. So with just a handful of trusted networks, you can have access to exchange clinical documents with hundreds, if not thousands, of different facilities. So that's really great. And then obviously the scope and footprint is quite large, and in large part because of meaningful use and some of the historical regulation, we've seen pretty widespread adoption of this method of data exchange.
Excellent. On kind of that same vein, they obviously talked about the benefits of using these trusted networks. Mm-hmm. And I'd love to hear your thoughts on some of the challenges that product managers should be aware of before deciding to integrate using one of these methods. I know we've learned a lot through our experience. Brendan Keeler, who is in the chat, did a lot of this at Redox, so he might be dropping some knowledge bombs in the chat too.
Yeah, guest appearance from our resident expert, but I'll do my best to impersonate Brendan here. I think there are probably three key considerations to keep in mind. First, the CCDA, as I mentioned, is really valuable, but it's not going to power operational workflows. So if you want real-time lab results or to drive a scheduling workflow or financial transactions, that's all going to be outside of the trusted network scope. Some of these networks do have a roadmap and hope to expand into some more of those operational flows. I've seen DICOM imaging, for example, on some slides, but certainly nothing that we're seeing implemented today. The other thing, and this is coming from physicians who are in my ear, you should keep in mind just how lengthy and complex these documents can be. And the last thing you want to do is increase the burden on your end users by just shoving a bunch of data in their face and saying, hey, we ran a query and from this network, we got 15, 30-page documents. Hopefully you're able to read that. So keep that in mind as you're developing your product and your user experience. Synthesizing the data and making sure it's usable for end users will be really important. And then the third thing is to keep in mind the cost. You obviously are going to get a lot of efficiency in having the reduced friction or overhead of having to get all those agreements in place. But a number of these networks will have their own either upfront or ongoing costs, licensing fees that you have to keep in mind. And then for the most part, it requires a bi-directional engagement. So if you want the ability to query a network, you also have to be able to be queried yourself. And so what that can mean for a vendor, and this is often an afterthought and catches groups by surprise, is if you join Care Quality, you have to be able to respond to any queries from anyone else on the Care Quality network. And so not only respond to patient search queries, but also you have to generate a CDA and then send that off to the requesting parties. One of our partners saw, just for a single facility, 200,000 inbound queries a day, which, if you're thinking about it from an engineering problem standpoint, that's a lot to have to manage just for a single facility. And you can imagine having several hundred of those. Granted, that was from a super densely populated area in California, and it's definitely going to depend on geographics, but certainly don't be caught off guard and do your due diligence on what the upfront costs will be here.
Yeah, thanks for sharing those insights. I'm also going to do a quick plug. We are going to do another webinar in a few weeks with Brendan, who I mentioned, specifically on care quality. A lot of things that we've learned and what we're seeing from our customers and how they're using care quality as an integration method. So if that's something you've been exploring or thinking about, or maybe you're already a part of and would like to hear more about what we've learned, definitely go ahead and click on that button at the bottom of the screen to sign up for that. Excellent. So moving into that next bucket, the EHR APIs. This is something that I know we run into very frequently, and sometimes people ask us, well, why would I use Redox if the EHR has an API that's available? As I mentioned, we've connected with maybe 15 or so different EHR APIs. It might be higher than that these days. Nija, I'd love to hear from you, because I know that this was something that you were really involved in, especially as we were beginning to do our initial connections to EHR APIs a few years ago. With the rise of these APIs provided by the EHR vendors, what should product managers and developers understand when thinking about this as a strategic way of increasing their integration footprint?
Yeah, happy to dive in. Man, it's just fun topic after fun topic. I think I'm going to have to restrict how long I'll drone on forever. But EHR APIs have been around for quite some time. We had early adopters really releasing RESTful APIs early on, which is exciting. And now we're even seeing some more of the late movers release those. Certainly, we should consider proprietary EHR APIs as well as FHIR as the future, and be prepared for that, which is really exciting and a whole lot better than flat files or faxing or even obviously HL7 v2. But they don't come, these APIs don't come without their fair share of challenges. So the first thing that we ran into early on was just the variance in implementation. So that can come in the form of versioning, but also if a specific health system hasn't implemented a particular module, or they haven't enabled piece of the EHR functionality, the corresponding APIs can drastically change in the way they behave. And so, you might think, hey, we're building out an adapter and connecting to a single API, but then as you actually deploy across hundreds of systems, that variance can catch your implementation team by surprise, and often means going back to the drawing board and having to update your own integration adapter. And then on a similar note, the workflows can also vary quite a bit across these APIs. So I'm picking on scheduling a little bit too much, but we've seen with some EHR APIs, you want to create an appointment, it's a single API call, and it's super smooth and designed well and easy to use. With others, it can be an exchange of 4 or 5 different endpoints, and you have to search for a patient. If the patient doesn't exist, create the patient, then link it to a particular facility, and then do all of these convoluted things in a workflow to eventually just be able to create that appointment. So that's something else to keep in mind. There's going to be quite a bit of variance, and I don't think that'll go away with FHIR, the adoption and implementation of FHIR either. And then the third thing is the actual content isn't being standardized. So you'll still have quite a bit of variation in the vocabulary or the specific data sets that you're getting. And obviously you'll want to provide a consistent experience to your end users. So visit types, different types of patient demographic categories, medication formularies, even procedure names, things like that will be highly dependent on however that provider systems customize their EHR. So all those things present some interesting challenges to, build a scalable solution that's highly efficient. But it certainly is the way of the future. So it's really exciting to see the the adoption both proactive, and then obviously the regulation is going to pull along those who haven't been first movers to get there as well.
Excellent. So that's kind of touching on the technical pieces of the different APIs that are provided by EHR vendors. I think the other question that's on a lot of our customers' minds is whether or not joining the marketplace or whatever type of offering an EHR vendor has, if that's going to be the fastest way for them to get integrated. Yi, I know you have some experience from your previous life. Would love to hear your thoughts on what it was like going through these marketplace programs and whether or not you thought that meant that you were able to get where you wanted to be faster with your product adoption.
Yeah, sure. Happy to talk about the thrilling adventures of joining EHR Marketplaces as a vendor. So the short answer, I think, is yes and no. There are PR components of joining an EHR Marketplace that kind of puts the right foot forward, so to speak, with some of these large health systems or provider customers that you want to have that kind of street cred with. But then there, beyond the marketing benefits of being able to do a PR announcement, make some kind of marketing splash that you're now in a marketplace now. Know that the health systems that we talk to, the health systems that I've become very well acquainted with, they're fully aware that these marketplaces have a limited set of vendors available to them because of a lot of the different financial burdens and the cost, the different revenue sharing models. They know that joining a marketplace can extract a heavy toll, if you will, on vendors, especially some of those earlier stage ones. I remember one marketplace we joined, kind of a year down the road, we were sprung with API transaction fees that, increased our costs to do business by, tens of thousands of dollars. And that's kind of just something that we had to deal with and we had to swallow because we wanted to stay in the marketplace. And, in terms of the speed to integration, I think Nijay, touched very, very well on this, that at the technical level, you're still going to have to do all the development work with the different formats and requirements for each different API. And, while a lot of our customers, we do see, reap the marketing benefits from joining these marketplaces, a lot of the value that they get out of working with Redox is being able to leverage the work that we've already done with these different APIs and to keep their integration processes very streamlined and very straightforward, so that their code complexity and the overhead get dramatically reduced. So when you're approaching these marketplaces, I think what I would be very wary of is to really weigh the potential benefits against those financial costs and the fact that the ROI may or may not be there. So yeah, definitely make those calculations.
Thanks for that insight. I think the other piece too that I know that you ran into, and especially as we've seen this huge increase in adoption of telehealth, is kind of like, what's the balance of, as a telehealth vendor, how should you expect to work with an EHR vendor that has their own telehealth module or potentially has plans to create their own in-house functionality, kind of towing that line between having a mutual customer that chose your solution over their EHR vendor, but still needing to work with that EHR vendor?
Right. Yeah. So there's definitely that business tension when you do work with an EHR vendor as part of their marketplace. And I certainly experienced it previously at Video, where some of our largest health system customers were under this one EHR vendor, and we a lot of times felt like we were at the mercy of the EHR vendor, whose incentives were very much misaligned with ours. Their goal was not to push our solution in their marketplace. Their goal was to eventually replace us with their own functionality. We tried very much to to hold a close relationship, but their roadmap was held very tightly to their chest. A lot of times when we're dealing with our large health system customers who are our flagship customers as well as theirs, a lot of times we felt like we were used kind of as a shield. Whenever the customers expressed some dissatisfaction with the workflow, how the EHR vendor pushed us out of an embedded workflow into a context-aware linking where the customer, the clinicians would have to click through 4 times to get to a virtual visit. And then whenever they just expressed that kind of dissatisfaction, we felt like we were used as a shield to say, oh, it's video's fault, it's not our fault. And then resolving technical issues was always kind of a game of ping pong where, they would point to us and we would say, this is really not on us. This was really, their API endpoint, not receiving the information correctly. And then at the end of the day, your customer is the one caught, between a rock and a hard place and caught in the middle. So, we saw a lot of that, and we knew that they were working on their own tele-ICU and e-sitter functionalities as part of their roadmap. Eventually, we found out. So, even when we worked with another EHR vendor that was more customer-oriented and friendlier, we still hit roadblocks with, kind of the scheduling workflow that Nijay had mentioned before. Very, very a little triggering, actually, like the 5 steps to create an appointment. Definitely true. And we felt like we had very little power over the EHR on how they would provide ongoing support for those APIs.
Thanks. Go ahead.
Just to quickly elaborate, I think it's also important to just consider who the core customer is for these vendors. And even if you are, as a vendor, paying fees or there's some sort of rev share agreement in place, they're still not thinking about you as a core customer. And so that's why I think we often see dragging the feet or not really incentivized to go above and beyond. We'll see how that shifts, but that's certainly what we're seeing today.
Thanks for that insight. Definitely great groups to work with, but being aware and having open eyes about what that experience and what to expect is important. John, I see your question. We'll hit that at the end. We've got one other set of questions, but we'll circle back on that one and tie it back together to make sure that tie to telehealth is clear. So the last set that we wanted to talk about is really that type of those integrations that you do that are direct with health systems. And when selling your product to a healthcare organization, it's a way to expand their ability to reach, communicate, and care for patients. But you're going to need to do some type of integration that's direct with that healthcare organization systems. Traditionally, this is done using those point-to-point connections that I mentioned earlier that are provisioned and made available by the healthcare provider themselves. Historically, this has been done using HL7, as Nijay's mentioned. But lately, we're also starting to see this happen with providers having the ability to provide access to locally implemented APIs. So there are definitely some healthcare organizations that created their own APIs instead of using their vendors' APIs. And the other thing, too, that obviously has been gathering steam over the past 6-7 years is FHIR. So because we know that FHIR often is something that comes up with people trying to determine how much of their integration strategy should be FHIR, Nijay, I'd love to hear your thoughts on if you think that HL7 is going to be replaced by FHIR. Is that really where people should be focusing on in the future?
Oh, yeah, great question. It's probably worth noting HL7 as an organization created FHIR. So I assume specifically we're talking about HL7 V2 compared to FHIR. And HL7 V2 has obviously been around for a really long time, and it's powering, millions upon millions of transactions every day across the country. And I don't think that'll change quickly, but I do think it will eventually be replaced by FHIR, and hopefully Redox and lots of other folks will play a big role in that transformation. But it won't be trivial by any means. Health systems are really, really complex. organizations and their infrastructure is, gets very, very, if you look at some of the architecture diagrams, it gets really messy really quick. So trying to untangle all of that and figure out, okay, we've had this pub sub HL7v2 method of communication. Now we're going to move to web services. Will be, time intensive and costly to do that transition. When we're thinking, maybe recency bias, but with everything else going on in the world and the other problems that these health systems are faced with, I don't expect this to be towards the top of their list in terms of retiring their legacy infrastructure and switching away to the more modern standards. Hopefully, regulation will accelerate that, but certainly I'd expect for the next 2 to 3 years for us to live in this hybrid world, where we'll see EHR APIs and FHIR increasing in adoption, especially for net new integrations. But HL7v2 will still play a prominent role in data exchange. Maybe the last thing I'll mention is it certainly does depend on the complexity of your workflow as well. If you're thinking about simple, basic, CCDA data exchange or historical data exchange, the web services and FHIR, I think, are well positioned to transition and replace some of the legacy methods of data exchange a lot sooner. But as soon as you get into the more complicated workflows, the bidirectional operational workflows, and that's really where you're unlocking more value to your end users, more efficiency across the board, those are going to continue to rely on HL7v2 and the legacy methods. They're tried and true and generally already in place on the health system side. So we'll expect to use both, whatever's available.
And Yi, I know that you've, over the past few months, have been working very closely with a lot of different health systems. I'm curious if you've heard anything about FHIR in some of the interviews and work that you've been doing.
Yeah, certainly. I think FHIR has been a hot topic, pun not intended, over the last several years. But it seems like there's been more steam than flame. But especially in the times of COVID. Sorry, guys, got a little carried away there. In the times of COVID, we've seen a lot of IT projects get pushed. And that's kind of just the reality that a lot of large health systems are facing these days, and small clinics as well. It's just that, working on efficiencies, things like cloud adoption, things like FHIR adoption, these things are kind of on the first line to get deferred. So we've seen that, as budgets get tightened, that's been happening. I've also personally, worked with a large health system in Pennsylvania that was a very enthusiastic early adopter of FHIR back when it was on version 2. So they took a chance there, and then when they quickly saw version 3 come out, they decided to skip that and keep going. And then when version 4 came out, that was supposed to be normative for FHIR. They decided it was the right time to upgrade. And then, unfortunately, many of their vendor integrations, including some of our customer companies, had to be redeveloped and redeployed, which took a lot of time and resources away from their IT teams. So I think that was a classic example of many health systems are still kind of dragging their feet, and they're kind of hedging on when is the right time to jump into FHIR, because healthcare providers, it's a followers market, right? It's very hard to see too many health systems jumping at the latest, shiniest thing. Everyone is kind of hedging around to see what their neighbor and their peer institutions are doing first. And then this was a classic example of this health system being the guinea pig, so to speak, and then regretting it afterwards.
Yeah, I think that's good detail. I think one of the things you mentioned, I liked I haven't heard that term of being a followers market. I think that's a really great way to describe healthcare. And kind of on that same vein, what we often see from different groups that we work with is that because there are challenges with being able to integrate directly with the health system and their systems, they want to talk about patient level authorization and authentication. So as a telehealth organization, you might be thinking, hey, and instead of trying to create all these relationships with healthcare organizations, especially if you have a service that's just for patients, should we be doing patient level authorization as a means for getting the data that we need? Mijay, I'd love to hear what you've learned about those patient auth APIs and how this can work as an integration strategy.
Yeah, for sure. I think patient authorized APIs, very similar like the trusted networks in terms of the advantages that they present. They've been around for, I think, much longer than a number of folks realize, and can be a great, again, another tool in the tool belt for increasing the breadth and availability of data. But there are some important caveats or challenges to keep in mind. I think the biggest one is, while you're reducing the level of overhead for having those agreements in place and having to work with every health system individually, you're still putting a burden on the patient to have those credentials. So we've seen patients increasing the utilization of these EHR portals, but it's still not, anywhere near 100% of the majority. So there's a high likelihood that a patient on your system won't actually have that set up, and the registration is still asynchronous and can take some time. So that's important to keep in mind, and why most groups we're working with might use patient authorized APIs to supplement data. And it's, hey, if you have a credentials, great, we'll use that to try and pull the information, but certainly not the end all be all for the integration. Hopefully that changes over time, and we're starting to see more and more patients sign up and utilize the online portals. So we can certainly expect that to increase. The other thing, similar to trusted networks, is the bidirectionality and the workflows that will be available. So if you're just trying to read basic clinical information, these API endpoints present a pretty straightforward way to get that information. But especially in telehealth, the real value comes in the bidirectional workflows, and that's where these, at least today, the patient authorized APIs won't be able to support comprehensively.
And any insights you have to share about the provider authorized APIs in terms of, does that help providers be able to do a bring your own app strategy or anything like that?
Yeah. Oh, provider authorized APIs are really exciting. We hear rumors of a few, I won't name names, but a few EHRs that are getting ready to release these. And it's really exciting. For me, the most exciting part of that, and again, provider APIs fall within the EHR API mindset, at least in my mind. And the thing I'm most excited about is around the authorization and permissioning aspect. So now you can piggyback on the rules engine already in place by these health systems to say this provider has access to this patient, and manage things like behavioral health situations, or where there might be break the glass workflows in place. You don't have to recreate that in your own solution. You can now follow the rules and infrastructure already in place by the health system. Without that, you kind of have to figure that out on your own. So I'm really excited about that. Obviously, that's going to bring a ton of complexity in implementation. So we're in a wait and see moment to see how the EHR vendors manage that and solve this problem. But I'm really excited to see those come to the market.
Excellent. And then the last question we have from our prepared content, and then I think we'll have a few minutes to take some questions at the end. But Yi, I know that at Video and at Genwa, you had the chance to work with a variety of healthcare organizations and different EHR vendors, implementing essentially the same telehealth platform. I'd love to hear a little bit about your insight on what it was like implementing telehealth across different groups, and what were the similarities and differences.
Yeah, I think one of the biggest challenges we run into often is, even if we're implementing across multiple sites using the same exact EHR system, often each integration was different. So it's different depending on the healthcare organization's environment, whether they were operating cloud, hybrid, on-premises. On-premises is a whole monster on its own. And what we found is that, even after we figured out this EHR integration at one site, it's not necessarily going to translate to a different EHR. And it's not necessarily, and it's not even necessary that it translates to a site with the same EHR system because of those environment factors. And so a lot of times, as I mentioned before, a customer can really run into roadblocks getting support from us and from the EHR vendor, because it's hard to troubleshoot issues when they're very specific to each custom integration. So these point-to-point integrations, you kind of have to think through to the end of the funnel where you're live, and you have to think about how to scale, how to support that integration on an ongoing basis. And it was very difficult for us as a vendor to, with a small support organization, to be able to draw patterns on what these issues are how these issues are coming up, because connectivity issues at one site with one EHR is going to be a completely different animal from connectivity issues at a different site, possibly with a different EHR. So what we found is that we needed to tackle each individual issue individually. And that was very, very challenging for our support organizations. So, kind of a shameless plug there is that I think coming to Redox, I've realized the value of being able to standardize these integrations, just from a support perspective of how much easier it would be to solve these issues across your customer base, as opposed to looking at each case on a case-by-case basis.
Excellent. Thanks. Thanks for that insight. We have a few minutes for questions. If you haven't had a chance to vote on the questions that were asked, drop those in. We're probably only going to get one or two in. John, I wanted to start with yours. You'd asked, what are the stumbling blocks specifically for telehealth that's unique to that industry? I'll start with an answer, because I've been doing quite a bit of diving into how do we articulate these needs for telehealth. Part of the reason why this is the content that we shared is, as we've done about 80, I think the number has been increasing every day with telehealth integrations, as I'm sure you all have felt. We've done about 80 telehealth integrations so far. And I would say that one of the biggest things that we've learned is that all of these different types of ways that we've discussed integrating are applicable for telehealth vendors. And some of our vendors have come in and said, our strategy is to connect with trusted networks, and that's how we're doing integrations. Others have said, our strategy is to connect directly to health systems, but then in starting their projects with health systems, the health systems were pointing them to health information exchange, or to use Care Quality, or to use Direct. And so in many cases, a lot of these customers that came to us, it was because they were realizing we had developed one way to do this integration that we thought was going to be just our strategy, but in reality, we need to do all of these different types of integrations. And the effort of doing that just started to get really high in terms of their engineering team now becoming more of an integration team rather than an engineering team that's creating a great telehealth product. So I would say that that's one of the big stumbling blocks, is just compared to other types of groups we work with, telehealth seems to have the biggest variety in terms of the needs of different healthcare data sources that they need to work with to be able to provide that great care for patients. The second one that I would add for telehealth that we see in particular is a lot of telehealth vendors, especially if you are a new telehealth vendor, come onto the scene and want to do very deep integration for your first few projects, and you want to integrate 4, 5, 6 types of data. And usually health systems can be somewhat resistant to doing that with groups that don't have proven integration capabilities. And so a lot of times, one of the things that we recommend to our telehealth customers is to start with a core integration of getting the basic patient data. Oftentimes there might be some sort of a scheduling component, and get that live first, and then work on expanding into those deeper pieces. Usually at that point, hopefully your users are loving your product, and they're going to be clamoring for it, so you can get more IT attention there. Yi and Nijay, I wanted to give you a chance to see if you had any other nuggets of telehealth specific pieces to drop to.
Yeah, I actually, I was looking at that question, and things were, the gears were turning a little bit. Definitely, I think outside of interoperability, some of the biggest things that I've seen in my work are more so like business challenges in implementing a telehealth solution. one side being onboarding, user onboarding. So are you optimizing the onboarding flow for providers and patients? Those are some of the biggest challenges that we ran into at my previous organizations, where, if it takes 4 clicks, if it takes 15 minutes for a patient to onboard to your telehealth solution, there's a huge drop-off rate. You're going to see that attrition. Providers don't have a lot of time to sit there and check their devices and put in all of their information. So to what extent you can streamline the onboarding process of users onto your solution to get them live in an encounter as soon as possible, that really helps your solution's adoption. And then the second aspect is the utilization piece. As telehealth providers, either offering your services to existing healthcare provider organizations or direct to consumer, one of the biggest challenges is proving that you have enough utilization to actually realize those cost savings. So a lot of times, it means, do you have a virtual waiting room? Are you optimizing for the utilization of providers on your network? Are you proving that each encounter is well documented and will be sufficiently billed for? So all of those pieces of being able to prove that your solution has the right amount of utilization can make it or break it for telehealth solutions.
Thanks, Yi. We're going to do just one more question, which is the other one that was tied with highest votes. So the question was, could you provide more information on the requirements for bi-directional data exchanges? I think there's probably a few different ways that this question could go. Nijay, I'm going to put you on the spot a little bit for this to kind of get your thoughts on what we've learned about how to think about setting up your product to be able to both send and receive data.
Yeah, I'll try and keep this brief, keeping an eye on the clock. But with telehealth specifically, I think we're seeing this trend of recognizing that telehealth platforms can be an important source of data, both for patients or other providers who are trying to query. So that bidirectional data exchange is really important. The CCDA and utilizing trusted networks, obviously that's going to be one core component. Otherwise, there's just a huge amount of variance in how you take that source information and get it into the downstream site. It can be a push versus pull. So you should definitely expect to encounter both groups who are like, hey, after the patient visit, can you send in a summary? And this is the format that we're looking for, so we can incorporate it and put it into our patient record. In other cases, they'll prefer that information is stored, and like when there's a request, they'll query for it and grab it there. Obviously, all of the authentication methods that we've covered here today could be used, so that's another layer of complexity to keep in mind.
Excellent. That takes us to time. I just wanted to say thanks everybody for joining. Hopefully you learned something new today. If you want to learn more about care quality in particular, definitely make sure to click the button at the bottom and join us in our next webinar that will be coming up. We hope to talk to all of you and hope everyone stays safe and healthy.